Well, thank you very much, Dr. Cusimano, and it's a real honor to be invited to speak at your cardiac tumor conference. This is an amazing resource that you've been putting together for now 6 years now. We're in our sixth year, and quite a privilege as the Division of Urology to contribute to this. You know, it's pretty rare occurrence where our tumor spaces overlap, but when it does, as we're going to talk about today, it's a pretty serious situation, and it's good that we spent some time today talking about this complex scenario so that we can do the best outcome possible for our patients. And without further ado, I'd like to introduce Dr. Kristen McAlpine, who's one of our fellows completing the Society of Urologic Oncology Fellowship with us here at the University Health Network. She's from Ottawa University. She's spending 2 years with us, and not only is she conducting research in kidney cancer and quality outcomes of surgical principles in kidney cancer, but completing her Master's of Health Sciences here at the University of Toronto. And this topic is right in her wheelhouse. And so when we heard about this topic, we thought this would be perfect for Dr. McAlpine to take the lead, and she's put the lion's share of this together. And so without further ado, Kristen, please take it away.
Thank you very much for the introduction, Dr. Hamilton, and thank you for the opportunity to present today. We'll begin with a case presentation of a 57-year-old gentleman who's seen by his family physician for blood in his urine and abdominal pain. He's healthy apart from high blood pressure, active, and works as a teacher. An ultrasound is performed and the findings are confirmed on a CT scan of an 8-centimeter vascular right renal mass with tumor thrombus extending into the IVC. The patient is referred to a urologic oncologist for further assessment and management. Genitourinary tumors may involve the heart, although it is pretty uncommon finding. Typically, when we see genitourinary tumors that involve the heart, we're talking about kidney tumors or kidney cancers. Most commonly, we see renal cell carcinomas. About 7% of patients may have cardiac involvement, and that is largely to do with tumor thrombus that extends towards the heart. Wilms tumors, which is the most common type of kidney cancer in the pediatric population, can also involve the heart, as can angiomyolipomas, which are a benign kidney tumor. There are other types of genitourinary cancers that can involve the heart, including urothelial cell carcinoma, adrenal gland cancer, prostate cancer, and testicular cancer. But as you can see, these are very low in frequency and not something that we commonly experience with our patients. So today we're going to break our talk down into 3 sections. The first is going to be genitourinary tumors that extend to the heart. And these are the vast majority of patients that we see. And so we'll talk about the presentation, the workup, the management, and the prognosis for these patients. Next, we'll talk about genitourinary tumors that metastasize to the heart, and finally, genitourinary tumors that invade the heart. So first, we'll talk about genitourinary tumors that extend to the heart. And again, these are largely tumors with thrombus that is extended through the IVC and into the right atrium. Renal cell carcinoma is the most common type of kidney cancer in the adult population and makes up the majority of patients that we see with tumor thrombus that extends towards the atrium. Renal cell carcinoma, actually, the majority of patients are now being detected incidentally with small renal masses and are asymptomatic. However, these are not all patients, and about 4 to 10% will have larger tumors that have venous system extension, and about 1% of patients overall will have extension into the right atrium of the tumor thrombus. So unlike patients who present with a small renal mass, who are largely asymptomatic, patients who present with an IVC thrombus are, for the vast majority of these patients are symptomatic. So as you can see here, many of these patients have blood in their urine, abdominal pain, peripheral edema. Some can present with pulmonary emboli, varicoceles, claudication, Budd-Chiari syndrome, and scrotal swelling. And the minority of patients, about 15%, will present with no symptoms. When we see a new patient with a renal cell carcinoma that involves tumor thrombus, they need to be thoroughly investigated before we talk about management, whether that be surgical or systemic. First, we perform TNM staging, and for patients with a kidney tumor, that involves CT scans of the chest, abdomen, and pelvis, a bone scan, as these would be considered more advanced cases, and blood work of CBC, electrolytes, creatinine, LFTs, calcium, and the coagulation profile. With regards to actually looking at the tumor thrombus itself, Several studies have shown that the most specific and sensitive test to assess the tumor thrombus is an MRI with T1 weighted images, including contrast and breath hold. And then finally, patients require an echocardiogram, and transesophageal echocardiogram is the best to look at the posterior and inferior aspects of the heart, including the right atrium. So these are performed on these patients before we consider their management. It is critical that the imaging is up to date at the time of patient's operation, because these tumors can be very dynamic and can change over a manner of days to weeks. And so if possible, imaging within 2 weeks of surgery is ideal, but imaging should not be greater than 4 weeks from their surgery because these tumors can change over time. There are two types of thrombus when a patient presents with RCC that extends into the cava towards the heart. The first is tumor thrombus. So tumor thrombus is actually the extension of the tumor into the venous system, into the IVC and towards the atrium as well. In contrast, bland thrombus is just clot that has formed around the tumor thrombus secondary to hemostasis and coagulopathy. And it is important to determine what type of thrombus is present, as thrombosis experts will determine whether a patient needs to be on perioperative anticoagulation based on the tumor thrombus characteristics. So on imaging, tumor thrombus will enhance. It'll be contiguous with the tumor. It has the ability to expand the vessel that it's within, and it can invade the vessel wall, whereas bland thrombus will not have any of these characteristics. Tumor thrombus itself has its own staging system, which is shown here. So level 0 involves the tumor thrombus just invading into the renal vein. A level 1 thrombus extends into the IVC within 2 centimeters of the renal vein. A level 2 thrombus is beyond 2 centimeters from the renal vein, but below the hepatic veins. A level 3 thrombus is above the hepatic veins, but below the diaphragm. And a level 4 thrombus, which will be what we're talking about for the majority of today's presentation, is a thrombus that is extended above the diaphragm and into the right atrium. And so clearly these will be the cases that require cardiac surgery involvement to assist with this component of the tumor. So let's go back to our case. Our 57-year-old gentleman undergoes full staging investigations and has no metastatic disease. He also has normal cardiac function. He undergoes an MRI, which shows a mix of tumor thrombus and bland thrombus that is extended into the right atrium. And he is referred to see a multidisciplinary team of experts to plan for a large procedure, as he would like to have a surgical resection. Intra-operative management of these patients depends a lot on the level of the tumor thrombus. And again, today we're going to be talking about level 4 thrombus, which extends above the diaphragm into the right atrium. And as you can see, this requires the involvement of cardiothoracic surgery because there is the potential need for thoracotomy and open heart surgery. That being said, you also need some of the other specialists that are in the other levels, like hepatobiliary surgery, because you will need to fully mobilize the liver and expose the IVC in these operations as well. Patients will be seen by a multidisciplinary team of experts based on, given the complexity of these procedures. So usually the referral comes to the urologic oncologist first, but again, hepatobiliary is often involved in these cases for mobilization of the liver. Cardiac surgery is very important, both in terms of whether there's going to be a component of the tumor thrombus in the atrium that needs to be resected, but also because of the potential need for bypass during these operations, which we'll talk about further. But cardiac surgery is integral to the management, assessment, and perioperative care of these patients. Vascular surgery may be involved if there is tumor thrombus that is extending into the IVC wall that needs to be resected and grafted. Cardiology assesses the patient's cardiac function preoperatively, and there's some discussion about if a patient's going to need to go on bypass, whether an angiogram is necessary. An anesthesiologist with advanced training in cardiac surgery is critical. These patients need intraoperative TEEs but also they can have the need to go on bypass. They may have significant blood loss, and there may be significant changes in their hemodynamics intraoperatively. So an anesthesiologist who is comfortable with these cases is critical to be involved in the care of these patients. And finally, like we mentioned, thrombosis for perioperative anticoagulation are often involved in these patients' care as well. With regards to what's actually needed for the operation, for operative planning, transesophageal echocardiogram needs to be available. And we'll talk further about why and the benefits of having TEE intraoperatively. Although not all patients will need to go on bypass, it is a possibility. And so having that available and the patient being operated on in a center where bypass could be readily accessed is essential. And again, there may be sudden drops in the blood pressure when the IVC is clamped, or a significant amount of blood loss during these cases. And so there needs to be a plan for these intraoperative events. So whether that means banking significant blood or being ready for a massive transfusion protocol, these cases are complex, and there's a lot of planning that goes into the operative, into planning their operation. So with regards to the need for intraoperative transesophageal echocardiogram, there are several benefits to having TEE intraoperatively. First, like we've previously mentioned, these tumors are dynamic and can change over a matter of days to weeks. And so having a TEE at the start of the case can allow for updated staging. So assessment to see if the tumor has changed at all, as well as surgical planning to see if there's been a change in the extent of the tumor or the fragility of the tumor thrombus. Intraoperatively, TEE can look at the tumor fragility, the adherence to the atria, as well as after it's been removed, if there's been complete resection. And finally, with regards to hemodynamics, a TEE can allow for assessment of the patient's hemodynamics to see if there's been any changes indicative of a PE intraoperatively, whether there's been any concerns for fluid balance, as well as ventricular function at the time of the operation. My last slide before I hand it over to Dr. Hamilton is bypass is a possibility in these operations as well. Now, again, you're the experts in cardiac surgery, is the expert in bypass and the need for the timing of bypass and how to put a patient on an F pump. But typically when we think about these procedures, it's patients who need an atriotomy, or if they're going to have suprahepatic clamping of the IVC, where there's not going to be any return of venous blood from the lower half of the body. Those would be patients that would be at risk for needing bypass. Benefits, depending on the type of bypass used, is it allows for a bloodless field and oxygenation of the organs. Harms, it may prolong the operating time and the patient's coagulopathy. And then the two types, venous-venous bypass versus cardiopulmonary bypass with deep hypothermic circulatory arrest. Again, that's your area of expertise. And so we work in conjunction with the cardiac surgery team around this. But we are aware that patients may need to be on bypass during these procedures.
Thanks, Dr. McAlpine. So I'll take over a little bit from here and just spend a couple minutes speaking about the actual intraoperative component, and obviously the abdominal component. As cardiac surgeons, you may not be involved, but I think it's worthwhile going through so you at least understand some of the principles, and then as we extend up into the chest, obviously you'll be more familiar with that. On the left-hand side of the screen, you'll see this particular incision was drawn here as a chevron with an extension into the chest as the sternotomy, and that's one option. If you don't know for certain that you're going to require a sternotomy, in some ways that chevron may be more advantageous. I have to say, at the University Health Network, for all of these cases, even if there's only a remotest chance of needing to go into the chest, we prefer a laparotomy so that you can just extend into an external laparotomy and access all of this through a midline. That's our preferred approach to many of our kidney tumors. And so we think of the operation in four components, the first being control and setup of the kidney dissection, two being mobilization of the liver, which we'll show you pictures of, three being setup and gaining control of the inferior vena cava, and then finally four is where you play a particular key role, which is access to the right atrium. And so this just shows step one, and the majority of tumor thrombi in the kidney come from the right kidney. It is more rare to have the left kidney. When the left kidney is involved, it's a little bit more complicated. You have to tunnel through the mesentery of the colon and almost make the left kidney almost become like a right-sided kidney, so you have that linear access up the IVC. But nonetheless, the first step of the operation, and here on this slide we've shown a right-sided tumor, is to gain control of the right renal artery in the intra-aortic cable space, so underneath the left renal vein. The idea being you want to minimize your disruption to the right of the vena cava, because that's where your thrombus is extending from the right renal vein. And to whatever extent possible, you want to minimize your disruption of that field to avoid breaking off a thrombus and causing a massive emboli situation. So we gain control of the renal artery at the intra-aortic cable space. And it is common to actually clip the artery at that time, because by taking away the blood supply, oftentimes you can have shrinkage of your thrombus. And not only does that minimize bleeding, but it actually may allow you to put your proximal clamp lower than where you may normally put it. And if your tumor is just poking into the atrium, sometimes by taking away the blood supply, you can get just enough shrinkage of that thrombus that maybe you don't need to go into the atrium. It doesn't always work, but sometimes there are advantages to early control of the artery. So that's how we gain control of the artery. We minimize mobilization of our handling, I guess, of our kidney at that point. It's controversial, actually, whether you completely mobilize the kidney. I prefer to have the kidney totally mobilized so that when you're ready to go on the thrombus, the specimen will be able to come out. The next step is to completely mobilize the liver out of the right aspect of the upper abdomen, and so that you can have this gorgeous view of the longitudinal view of the vena cava. You can take the accessory hepatic so that you're only staying with the main, you're only keeping the main hepatic veins. And it's key to, obviously avoid clamping, not only for ischemic venous drainage of the liver, but also a huge portion of your venous return comes from the hepatic veins. And so you leave that till the end whenever possible. So once you're done mobilization of the tumor and then the liver, that's where we start our discussions with you in terms of when to do the sternotomy. And there are many cases in the literature that argue early sternotomy will make our dissection, not only of the kidney, mobilization of the liver, access to the upper aspect, suprahepatic aspect of the vena cava, way easier. And so I think if you know you're going to go into the chest, the earlier you can create the sternotomy, probably the better and more advantageous. But once you have that complete exposure, including up to the atrium, then we can start clamping our vessels, not only to the right kidney, the affected kidney, the contralateral kidney as well, gaining your occlusion of your inferior control on your vena cava and setting up control of your proximal vena cava. If you're above the hepatic veins, you obviously need to perform the Pringle maneuver on the liver to decrease your venous flow for coming back from your liver. Obviously, if you have already made your decision that we're going to go on pump for this case, that will have had to already set up and initiated before you open the vena cava. Once you open the vena cava, you need to assess the resectability and mobilization of the thrombus within the vena cava. There are times, we didn't talk about it in today's case because I think it's a bit out of topic, but there are some predictors pre-op of whether this thrombus is actually invasive of the wall of the vena cava, and you may need to resect a portion and graft a portion of the vena cava. Once you've started to mobilize that, we work our way up to the atrium. And there's two ways, and I put this one on the left here to show that there are some times where a thrombus is just poking into the atrium. Sometimes you can pull everything down by dissecting up through the diaphragm a little bit. You can pull down and gain control from within the abdomen and resect the thrombus that way without having to make a formal incision in the pericardium and into the atrium and controlling this way. But on the right is more relevant to what we're talking about today, those classic stage level 4 thrombi, where we absolutely need your assistance to get into the atrium, visualize the thrombus, and help us with our dissection there. The options, as we've illustrated here, once we have exposure to the atrium, you can either break off the thrombus, which I think is arguably less desirable, break off the thrombus and pull out the atrial portion and then pull down the separate portion from the vena cava inferiorly, or the cardiothoracic surgeon can simply protrude the thrombus down into the abdominal portion, and then us as urologists can pull down the thrombus and completely excise the tumor in toto. And I think that, when possible, is probably preferable, certainly from a pathological standpoint. And then we close our atriotomy, our cavotomy, reperfuse our organs, make sure we have hemostasis and good tumor control. Check with your TEE to make sure that you've satisfactory, you're happy with your dissection of the thrombus, and then close. I think it's important to point out that not only as you go up in level of thrombus, obviously the prevalence of those cases goes down. So the prevalence of level 4 thrombus is very rare. But when you are into a level 4 thrombus into the atrium, the complexity is exponentially greater. So not only operative time, you can pretty much bank on a full day case. Median time here was 11 hours. A 9-fold increase in rate of transfusion, 6-fold increase in the total amount of blood loss. So you really exponentially level up on your degree of complexity when you enter the atrium. And I think as a surgical team, you need to be prepared for that. And on that note, we thought it'd be worthwhile to put this in as a side note. This is work that's done at the University Health Network looking at the Ontario population level data and predictors of mortality with nephrectomy associated with either renal vein or IVC thrombosis. And what the key point we wanted to point out was that when Dr. Finelli and his team analyzed the data based on volume of experience of the surgeon, and they broke it down to one case of IVC thrombus in a 10-year period versus more than one case of IVC thrombus in a 10-year period. And you can see dramatic differences in both 30-day and 90-day mortality when analyzed by surgeon volume. And so I think it's just important to point out, and it may seem obvious, but if you're a cardiac surgeon being approached by a urologist who has discovered a tumor, I think it's important to have that conversation to say, well, how many of these have we done, and should we think about optimizing the patient's chance for living, and ensure that we do this at centers that have sufficient experience in order to optimize that patient's chance of survival. And so with that, I will hand back over to Dr. McAlpine to finish the talk.
Thank you very much, Dr. Hamilton. So we're just going to talk a little bit about some of the controversial topics with regards to nephrectomy and IVC thrombectomy. The first is preoperative angioembolization of these tumors. So having interventional radiology embolize the entire kidney preoperatively. The rationale for that is that you can decrease the blood flow to the kidney and potentially have some retraction of the thrombus, like Dr. Hamilton mentioned, and potentially decreased operative time, decreased blood loss. However, there are some drawbacks. Patients can have fairly significant post-embolization syndrome after that. There's not really any change to overall survival, and it often delays the start of the OR if this is planned for the morning of the procedure. And it's felt to be not necessary for these operations. The second controversial topic is the use of IVC filters. There are risks to placing the filters, as you can imagine, alongside the tumor thrombus in the IVC preoperatively. It can be quite challenging to manage in the OR. And really, they're not recommended unless a patient is developing persistent PEs despite full anticoagulation preoperatively. With regards to prognosis of these patients, these are complex operations that are high risk, and patients have a 3 to 10% perioperative mortality rate. Many patients will have major complications, and as you can see, VTE is the most common complication, but also respiratory failure, hemorrhage, cardiac complications, including myocardial infarctions, are not uncommon. The 5-year cancer-specific mortality rate, cancer-specific survival rate does depend on how you define the population, but it's around 25 to 60%. With regards to patients who present with metastatic disease, about 30 to 40% of patients who do have a thrombus that extends to the right atria will have metastatic disease. Surgery in some studies has shown to improve survival. However, we do acknowledge that this is likely very biased data, as patients who went on to the OR were likely more robust compared to those who did not receive an OR, but there is maybe some signal that patients did better. Beyond survival, surgery does help to limit symptoms and can help prevent sudden death from a massive PE for these patients. The next two graphs will show the prognosis based on different subgroups. So in this graph, years from nephrectomy is on the x-axis, disease-specific survival on the y-axis. And you can see that overall, about 40% cancer-specific survival at 5 years, but that it varies significantly between the metastatic patients and those that do not have metastatic disease. And in this graph, you can see that incomplete resection, the patients who had an incomplete resection did much worse than those who had a complete resection. So we're going to move on to the next portion of our talk, which is genitourinary tumors that metastasize to the heart. Now, this is very uncommon for us to see with genitourinary malignancies, but it can occur with kidney cancer, prostate cancer, and bladder cancer. And typically, we see patients with cardiac metastases when they have advanced disease, and either they're starting systemic therapy or they are already on systemic therapy. In this table from the study, they looked at different cardiac metastases based on their prevalence. And you can see prostate cancer, kidney cancer, and bladder cancer have made this table. When you look deeper into the table, though, they did mention that patients with renal cell carcinoma with IVC thrombus counted as endocardial metastases, which is one of the reasons that that percentage is so high. So although it is uncommon, genitourinary tumors metastasizing to the heart can happen. Here we see a metastatic bladder cancer involving the myocardium and metastatic kidney cancer involving the endocardium. This is a nice flow chart looking at the management of cardiac masses. We look at this sometimes, although we acknowledge again that we are not the experts on cardiac masses. And so looking at these patients, they would have a malignant tumor that is secondary to another malignancy. And so typically we think of these patients requiring systemic therapy, but that's not a definite rule by any means. And we would look to the expertise of a cardiac surgeon if this is a patient who has a solitary met in the heart, as that would be your expertise for sure. Now moving on to the last portion of this talk. Genitourinary tumors that invade into the heart. This is exceptionally uncommon and really only case reports that we could find on this topic. You can have adrenal cortical carcinomas, which are cancers of the adrenal gland that are extremely aggressive, that can invade through the diaphragm and into the right atrium. There's a few case reports of that. And there are some case reports of metastatic thoracic lymph nodes from testicular cancer that have invaded into the heart. Again, very uncommon, but possible. So looking back at our case, our 57-year-old gentleman with an 8-centimeter right renal cell carcinoma and grade 4 tumor thrombus. He had extensive preoperative counseling and investigations by several members of the multidisciplinary team. He opted to proceed with a multidisciplinary full-day operation and is recovering well with his incision that you can see here. In conclusion, renal cell carcinoma is the most likely genitourinary cancer to involve the heart. Nephrectomy and thrombectomy are complex and high-stakes ORs, and imaging that is up to date is critical for these operations. It is very important to note that these patients need multidisciplinary assessment and planning, and that cardiac surgery is integral in the preoperative planning, the intraoperative decision-making, and the post-operative care of these patients, as this is not necessarily our area of expertise, but these patients are complex and require physicians from all aspects to give them a successful operation. And you can expect to have intraoperative decision-making as well. Finally, cardiac mets and invasion are very rare with genitourinary cancers, but they are possible. So we'd like to say, on behalf of myself and Dr. Hamilton, thank you very much for the opportunity to present today. We would be happy to answer any questions or comments during the question and answer period. And if there's questions beyond that, please feel free to email us at your convenience as well. Thank you for your time.
Thank you very much. That was, again, outstanding. You did a fantastic job on summarizing and telling us the pertinent points of everything. I think that was a great lecture, and I hope that everybody learned as much as I did. And I've been dealing with these for a long time with a lot of you guys. some of those surgeons that I started with have retired. That's how long I've been doing them, and I learned today from that. So thank you very much for that. I'm going to make a couple of comments about the surgical aspect of the whole process. You were talking about whether we open the sternum early versus late. Certainly it does help you with respect to your resection. The intraoperative transesophageal echo does tell us whether it is going into the heart or not. And we had one case here specifically, and that's when I changed my thoughts, and that's when we changed our thoughts about this, where during the dissection, the patient embolized a portion of the tumor into the lungs and had a cardiac arrest on the table. And I happened to be very close, just coincidentally happened to be close to the OR. Up until then, I used to walk in and out and say, "You ready for me yet? Ready for me yet? Ready for me yet?" And this one, I happened to be in the OR when they called me stat. There was a code blue that came over the OR system, and I ran in, and we were able to save that person. I put him on bypass very quickly, and we saved his life. And ever since then, we always open up the sternum at the beginning of the case, and I stand and watch you guys dissect as well. This is of all the tumors that we operate upon that secondarily affect the heart, into the heart, this and perhaps the gynecological tumors are the ones where we have the most collaboration of different surgical teams. It's really, really important to have a hepatobiliary expert with us when we do these tumors that go through the inferior vena cava. I think is really important. And it's an idea about if you, and talking to the people that are watching from elsewhere, if you're going to get into this field as a cardiac surgeon, as a urologic oncologist, et cetera, you better make sure you have a really, really good cohort of people that can help you get out of trouble. The bleeding is obviously a big thing. I mentioned it in my talk at the very beginning as a general comment that bleeding is a significant problem when other organs invade the heart. And I think part of it has to do with the magnitude of the resection that's happening. But you showed us level 3 or stage 3 versus stage 4. The magnitude of an operation in stage 3 is pretty big. And the bleeding, I think, comes in part, probably in a large part, related to the coagulopathy that occurs when we go on bypass and when we use circulatory arrest. Circulatory arrest is an integral part of this. And circulatory arrest is used not because I have to have circulatory arrest when we push the tumor down into the infradiaphragmatic portion of the vena cava. Circulatory arrest is required to reduce all of the bleeding around the operation that you need to do once I go and push it down for you. I'm going to have a one question because I don't want to take up all the time. Dr. Rogala has a comment to make, and perhaps he can do it in person. Is there any way to tell in a good way whether the tumor invades through into the wall? Because I know I've been involved in a number of them where it obviously has invaded. And would you ever use systemic therapy in those people prior to? I know we use embolization in some individuals, but what about systemic therapy prior to going to the operating room? Can you comment about that?
Yeah, it's a great question. Kristen, why don't you go first, and then I can chip on top, but it's a great question.
Yes, thank you, Dr. Cusimano. So typically, with regards to whether the thrombus actually invades into the IVC, again, MRI can help us with that a little bit. There can be some signals on the MRI. And so going into some cases, we have an idea that the thrombus does invade into the IVC, whether that be in a small percentage of the IVC or there's extensive resection. We do have some ideas going into the case usually. With regards to systemic therapy prior to these operations, it's a bit challenging because the thrombus itself, and if there's bland thrombus around the tumor thrombus, is a threat to the patient's life and can be challenging for people to be on months of systemic therapy. I have seen some patients who have had like lymphadenopathy and potentially metastatic disease that they give almost like a litmus test of systemic therapy before the operation to see if the patient's going to do okay. But I think Dr. Hamilton will be able to comment on this. Typically, we try to get them to the OR to debulk them and to get that tumor thrombus out of there before then. Many patients will go on systemic therapy after as well.
Yeah, great answer, Kristen. And actually, we can tie Dr. Rogala's question into this. Interestingly, it just occurred to me. So there are some radiographic factors that we use at least below the diaphragm to get some sense of whether this is going to be invasive or not at the time of surgery. And Chris is absolutely right. The MRI is helpful. TE can help with that. But there are some factors, for example, if we look at the diameter of the ostium of the renal vein as it comes to the IVC, and of course, Dr. Rogala just came live, so he can answer this even better than me. The diameter of the IVC, these are factors that we use to glean whether when we get in there, this thing is going to have its roots into the wall of the IVC, or it's just going to be able to be plucked out. To answer the question of systemic therapy, so first let's answer Dr. Rogala's question about staging, because it matters. So technically, the level of IVC thrombus, the presence of IVC thrombus is tucked in under the T stage. And so T3 ABC correlates with our extent of thrombus. So it doesn't actually count as either a nodal or a distant metastasis. So technically, you can have a embolus all the way up to the atrium and you'll still be without node or metastatic disease. And so what that means is that a lot of the systemic therapy trials, in fact, all the systemic therapy trials did not include these types of patients in them. And not to divert on a urological tangent, but the field has changed in the last 3 years for metastatic disease. We used to think, oh, we have to go in and take out the primary tumor and then give them systemic therapy afterwards because they have this giant kidney and they'll survive better. And we have some retrospective series that tell us that that's true. New trials now point towards systemic therapy first to gain cytoreduction, and then maybe later you go in and consolidate by removing the primary tumor. But an IVC thrombus doesn't really count as that metastatic disease. And so I think we really don't know whether there's a role for giving systemic therapy to someone with just an IVC thrombus. And I agree with Kristen, there is a concern. You worry about the imminent life-threatening nature of an IVC thrombus, that if you put someone on a VEGF receptor inhibitor, that you're going to have a catastrophic event 2 weeks, 4 weeks, 2 months into their therapy. So you worry a little bit about that. So those are good questions. Hopefully we've covered it all in one answer there.
What about the smaller tumors? We're talking about the stage 4 tumors now. Would you ever use cytoreduction in the smaller tumors?
So yeah, in the setting of metastatic disease, yes. In the setting of non-metastatic disease, no, there's no role for that. And the reality is because the degree of reduction you get in the primary tumor with systemic therapy is only about 15 to 20, 25% in the trials. So you just don't get a massive involution of the primary tumor with systemic therapy. So unless there's metastatic disease, there's really no role for systemic therapy up front.
How often do you see bland thrombus, do you think? I must say that of all the tumor resections I've done and of all the tumors that come from elsewhere, urological tumors are the most common. I've never seen bland thrombus.
Yeah, and Dr. McAlpine can chip in, and even Dr. Rogala. I have trouble distinguishing bland from tumor thrombus. And I know Kristen showed that nice table and it looks great on paper, but I have trouble in reality going into the surgery going, oh yeah, this is the bland, this is the malignant. And maybe there are people with more intraoperative experience that know 100% going in, but I find it very challenging. And also, RJ, I have not personally had a case where I've had bland thrombus. I had one where the proximal propagation of thrombus was malignant. The distal propagation, almost retrograde backfilling on the cava, that was bland. But all the proximals that I've had have been malignant in nature. I don't know, Kristen, do you want to comment? And maybe Patrick, you can comment from a radiological standpoint.
Yes, so we talked a little bit about the differentiation between bland and tumor thrombus, and I have seen a couple patients, this was in Ottawa, with bland thrombus. They were advanced disease patients, and it really, the main thing that mattered was the perioperative anticoagulation that they were going to go on. Because the bland thrombus has, I believe, a higher risk of thrombosing off and causing PEs preoperatively. And so that was mostly, again, on MRI that was determined, but I think I've seen 2 or 3 with bland thrombus who then went on to full dose anticoagulation preoperatively. And then intraoperatively, I'm not sure in terms of whether there was still bland thrombus present or not. But it mattered for the thrombosis experts to determine their anticoagulation.
What I've noticed is that in the OR, and Patrick, I want you to comment about it from a radiological point of view, is that we do see portions of the tumor that are obviously alive and portions of the tumor that are obviously necrotic. And again, I've seen it, all the bland thrombus I've ever seen in the renal cells or the sarcomas, the hepatocellular stuff has always been upstream, in other words, inferior to the tumor, stuff that blocks up into it. Patrick, can you talk to us about that?
Yeah. So I can echo what Dr. Hamilton just said. I find it very challenging to give a definitive answer. If we see vascularity, we see the enhancement of the tumor, both on MRI and CT, it's easy to call. Sometimes it's equivocal, we don't know, then we err on the side of calling it a tumor, but there will be cases in which we simply can't say. And as you said, I'm very reluctant to definitively say it's only thrombus. I don't even know how the biology would actually work unless there's some sort of internal structure that holds the thrombus together, given the flow. So I would actually echo a big caution on calling it just bland thrombus. I would rather lean to a diagnosis of we don't know. And that then goes back to you, and you have to make the call whether you have all the precautionary measures or no. I hope that's a fair answer.
Yes, it is. One final question, unless somebody else wants to ask a question here, is that what about anticoagulation post-op?
Yeah, that's a great question. The pre-op question, we have very little concrete guidance on that. If you read textbooks and guidelines, they say as soon as you identify a patient with an IVC thrombus, they should be on anticoagulation up till and including their OR and thereafter. But many experts in the field who do high volume cases of this say, nah, you don't need to unless you're worried about a flapping bland thrombus. They say post-op is a different story, and we sort of adapt our guidance from other large thrombogenic tumors that we deal with. And I think generally speaking, we place these patients on prolonged anticoagulation post-op. I think you have to just make your intraoperative bleeding risk assessment guess as best you can, and maybe you hold off on full dose anticoagulation until you see that they've stabilized, and their hemoglobin stabilized. But we don't have a lot of great strong guidelines on that post-op for thrombectomies.
And are you using dabigatran or DOACs or warfarin?
Yeah, so truthfully, we sort of leave it up to the guidance of the thrombosis team. I feel like historically with cancer-based pathologies at the root of the thrombosis, they have preferred low molecular weight heparin-based up until recently, and Kristen's nodding her head. But in the last, say, 2 years, I feel like there's been a cultural change towards the DOACs. I'm sure you guys have much more experience with that than us, but that's been the general flavor. Kristen, that's your take as well?
Yeah. There's so typically these patients would fall into the category of our extended duration prophylaxis, and they'd go home with 28 days of inox. But there are some trials actually going on in urology, not just in the kidney cancer space, but the bigger all urologic oncology space, to see about exactly that, the DOACs for 28 days postoperatively versus enoxaparin, comparing bleeding and VTE risks. Just for simplicity of taking an oral medication versus an injection. But typically, I think either in Ottawa and I think here as well, patients would go on enoxaparin at this point. But DOACs are certainly what is being studied at this point as well.
And is a tumor that goes into the heart without metastatic or nodal disease enough to give a person systemic therapy post-op?
So that you've touched on another great controversial topic in urology. Up until recently, the answer was an emphatic no. We had no good evidence for that. There's been 4 adjuvant systemic therapy trials that have been done. Only one has showed a slight marginal benefit for the very advanced local stage tumors with targeted therapy. So Sutent, for example, sunitinib. Most of the field's interpretation on that is the benefit of giving a medium toxicity systemic agent to these patients post-op for a very marginal benefit in recurrence-free survival is not worth the cost to the patient, the cost to the system, the toxicity, et cetera. So most medical oncologists, if you refer these patients to them post-op, they don't want to give, because their take on the literature is the same, that it's not worth it.